choice of an articulator depends on the number of maxillomandibular records or jaw relation records that we want to make on the patient. It also depends on the type of occlusion which we would like to formulate for each individual patient. Now, in order to know this, since there are so many instruments available, we will have to examine the number of instruments which are actually in use today. Thus, the objectives in this examination of the various instruments is, first of all, to survey them so that we become familiar with the design and function of the various instruments, to learn then a classification of articulators as might be appropriate to the number of maxillomandibular records made, and lastly, that we might select an articulator intelligently, again, as I mentioned earlier, according to the number of maxillomandibular records made on the patient. Now, a simple classification of instruments is as follows. First of all, we may have a simple holding instrument. This may be an instrument working on a hinge or vertically only. An average value instrument. Average values are built into the design of an instrument. The tripod instrument, which, as the name implies, actually works on three legs, we might call them, built into the instrument, and an adjustable axis instrument. When we have mandibular motion that we like to simulate on an instrument, we deal with a number of axes. We'll discuss these a little bit after, and that's why we say plural, that these are instruments which are adjustable axes instruments. All right, the first thing we need to do, however, is to think about how do we get maxillomandibular records onto the articulator anyway. The first axis to consider is the transverse, or the horizontal axis as it is also called. Now, we might select this axis arbitrarily by facial measurements, or we may use a hinge bow, which then would make it a hinge axis for transfer. The second way of doing it might be to use a reference plane, such as using the transverse axis or the horizontal axis and a third point anteriorly, usually somewhere in the region of the nose. The two then, the axis and the point, produce the reference plane by which a transfer is made, or to which a transfer is made. Another way of doing it would be to consider the interfacial width. Now we're working actually with the vertical axes too, the placement of the vertical axis about each condyle. So we're concerned then in a facebow transfer with a transfer or horizontal axis and a vertical axis, and it depends how far we go in terms of, again, the selection of the instrument to which we might transfer this record. Now, illustrating it a bit farther, we show here the transverse axis as might be represented through the condyles or near the condyles in the skull. This is an axis related to, of course, the maxilla. We may find this by arbitrary measurements on the face as 13 millimeters forward from the most posterior part of the tragus on a line to the corner of the eye. This is the usual one we take, 12 to 13 millimeters forward. There are other facial measurements that are used in other techniques, but this is the one we're concerned with by and large in our procedures at the school. So using just these 2 points and relating the axis in this fashion, we might make a facebow transfer without any other orientation. Now, when we get to the instrument, of course, we might adjust this on a horizontal in the instrument or any designated position on the arc of movement about this transverse axis. Another way now is to use the third point orientation. This is the orbital as used in the Hanno technique. We have an axis, a point. This now becomes a reference plane to which to mount on an instrument. As shown here. It's automatically incorporated in the design of the instrument, and we have the pointer go up to this position so that we have somewhat the same relationship now of the maxilla to the transverse or the horizontal axis. Another way of locating this transverse or horizontal axis is by a hinge bow. There are a number of hinge bows available. We have some here that we can use in the clinic. This is a somewhat different design than one we have. But the patient moves through an arc of about 15 degrees, and when we get an apparent stationary rotating point, it's stationary as far as translation, but it spins about itself, so to speak. We mark this on the side of the face. First, of course, on the card, but we take the card away and then mark it on the face, and this now becomes a hinge location. If we do it on both sides, then of course we have a hinge axis now with which to make a transfer to an instrument. Again, providing the instrument is so designed that it will accept this hinge transfer or hinge bow transfer. And as is illustrated over here, there are definite design functions in here where this previous bow that we had about the face can be oriented, and the cast is mounted in a similar way as the maxilla to this transverse axis. All right, the other axis we're concerned with are the vertical axes. We have one on each side. Of course, one when the mandible moves about, let's say towards the right, and then the other side, of course, moves to the left. Now, this position becomes critical in terms of the maxillomandibular records that we need to make in order to make this location. But we can start out with, first of all, by making a recording of the facial width, as with the Dana bow, illustrated on here. Again, here's our third point orientation that we spoke about earlier, making it a reference plane. In addition, now we're maintaining this facial or interfacial width to mount to an instrument. Showing merely that this happens to be a reading on this calibrated scale 58, but it means it's 116. That's only half, actually, the way the scale reads, so it's about 116 millimeter width in here, and they've already automatically translated this to the condylar region of this extendable rod, which simulates, of course, the instrument mechanism, as we see here, of course. So this reads 116 from here to about here. Now the facial width is, of course, a bit more. Usually we think of it 12 to 13 millimeters as far as being the distance from the external facial location that we made with the bow to the lateral border of the condyle. So it comes out to about 116 actually to the center of the condyle, or the center of rotation over here, as far as the calibrated scale that automatically gives you this position. So we adjust, of course, the instrument to that, and then the upper member that it's also adjusted to it. So now we have one at 116 instead of a standard width, an instrument which does not have this feature of adjustment out and in. A number of these are made without this adjustment, and they're about at 110 millimeters as a rule. So this is another feature, a refinement then, as far as the vertical axis location on the instrument, as you might have, or you do have in the skull in respect to the mandible. And here merely showing the anterior view, again with the anterior reference point, and here mounting it to a plane. A number of instruments will then be examined in relating these to the maxillomandibular records. The first thing we might consider beyond the faceable transfer, of course, is a centric relation record. Now, a centric relation record is required in every or for every instrument, no matter what the design might be. But in this first one, which is called a centriculator, and it moves only in a vertical direction, just up and down. It's sticking together here a little. All right, but we made a centric relation record, and we're mounting it to this position. This we call a simple holding instrument. In other words, this instrument is capable of holding this particular recorded position, and that's about all it can do. And it moves vertically. Another simple holding instrument would be one that moves on a hinge. And that's all it can do. It holds the centric jaw relation record, and that's about all the transfers that we need to make. This particular one does not even have an orientation for a faceable transfer, as of course the previous one did not have it either. Now the next would be one, a simple holding instrument again, utilizing only the centric relation record, also just on a hinge, but you see here incorporated an incisal pin. This now becomes an improvement in terms of holding this position. In other words, we don't have any bending of this instrument anyway. We can't go astray as far as the recorded vertical dimension between the jaws. So this anterior pin now holds this position more accurately. Still not able to make a faceable transfer. Now, without a faceable transfer, we should not ever change the vertical dimension of occlusion. As long as we're working within this recorded position, setting the teeth, later on checking out the case, which is rather difficult to do without changing the occlusal vertical dimension. But we cannot change the occlusal vertical dimension because we have not made a faceable transfer on these instruments up to now. These are simple holding instruments, holding a centric relation at a recorded occlusal vertical dimension, and that's all they're capable of doing. Now we get to the average value instrument. The average value instrument, we can now use a faceball. If we could come to this card once more here and show the next. Here we talked about a faceable transfer earlier, and I just said that in a simple holding instrument, it's necessary, a faceable transfer is necessary if the instrument is capable of doing, accepting this faceable transfer, and if we intend to change the occlusal vertical dimension at any time during any subsequent procedures. The next one then is the average value instrument and the adjustable articulator. Well, here we definitely should have a faceable transfer. In the last two, it would be strongly recommended that we use a faceable transfer, and this one will make it possible also then to orient it more accurately, the maxillary cast, to the joint mechanisms on the instrument. This is an average value instrument where the guiding mechanisms are set or predetermined in the design of the instrument on an average. This is the Gysi simplex instrument. It had been used for many years. Dr. Gysi in 1929 talked a great deal at various meetings about this instrument, because in the research that he had done, he found out that the number of patients, the majority, about 50%, or a bit more, had a 30-degree inclination of the condyle path in the fossa. He made external tracings on the faces of these individuals, and he found out that on the average there were about 30 degrees. So he incorporated that inclination in these mechanisms on the instrument. and it's a well-known instrument all across the country, still used widely. All of these, as I indicated earlier, are used currently across the country. All right? Now, if we want more information from the patient, we might make a centric relation record and also a protrusive record on the patient. Now we have two positions that we recorded. The protrusive, of course, we use to set the condylar inclination of the instrument. Now, beyond this one setting that this instrument is capable of accepting, everything is on a simulated basis. The lateral movements are simulated. Why? Because these positions are fixed. These elements are fixed. We cannot move them in or out. Therefore, we cannot accept anything beyond a protrusive record for most individuals. This is the one I spoke earlier in terms of Facebook transfers, which is set to about 110 millimeters as far as the distance between these elements. This gives you a little bit more information now, though, more individualized for each patient when we do set the condylar inclination for these patients with the protrusive record recorded on the patient. Now the next thing that came about, by the way, that instrument dates back to the 20s also, the Hanno instrument. But then in the 30s, Dr. Stansberg came along and he said, well, we really ought to have more information than just a protrusive record, such as this. So let's make also right and left lateral records on the patient. These are left and right lateral positional records in addition to the protrusive record. The centric relation record, of course, within the instrument here to which the casts were mounted. So he designed what has been called the tripod instrument. There are actually three legs on the instrument. These turrets are turned to adjust to each position recorded. They're marked down, of course, on the card. It's all calibrated, so every time you set a tooth or you grind on a tooth later on, you have to move all these turrets around to the particular recorded position in order to check out your occlusion. Now, this gives us more information. It's a good instrument, but it is very time-consuming to use because of this fact of changing these turrets to these individual positions recorded on the patient. One thing that is not necessary, one record that is not necessary on this particular instrument is a Facebook transfer. We're using it as a tripod, really. The instrument would be programmed to these positions, so we really don't need a Facebook transfer because of the design of the instrument, the way it is designed to function. So a tripod instrument not necessarily requires a Facebook transfer. Now essentially, we're using three records at this time with this instrument that we have come to know at the school, the Danar instrument. Now you can use this instrument only with a protrusive record, or you can make your additional lateral records. Particularly for complete dentures, you can go either way. However, again, it's a matter of getting more information from the patient with these lateral records, the right and left lateral records, and if we can set the instrument guides to these positions, then again we have more information recorded from the patient and transferred into the instrument. And we hope that we come out with a little better balanced occlusion in the end result. Now another thing I'd like to point out at this time, because it's the first time that we've come into this particular design, in addition to the classification of instruments that were reviewed a bit earlier, instruments are also known as archon and non-archon instruments. The last one that we had just discussed here is an archon instrument, which means that the path itself, the path that the condylar element down here traverses, is attached to the upper member of the instrument. In other words, the guiding path is on the upper member, the element is below, also called axial centers, are attached to the lower member of the instrument. In this particular one here, the path is attached to the lower member of the instrument. The path in which this condylar element rides is attached to the lower member of the instrument, and the axial center actually is attached to the upper member of the instrument. In other words, it's directly opposite to the other one. That's why one is called archon and the other one is called a non-archon instrument. Now, it's been found out by a number of investigations, mathematical analyses, that an archon instrument simulates mandibular movement a bit more close than the non-archon type. And hence, there are a multitude of instruments now available which have this archon design incorporated in rather simple instruments. It's not a new concept, this archon design. It dates way back in more sophisticated, more complicated instruments, way back to the 1920s. The earlier ones were actually of an archon design. But by and large, in general use, and particularly for complete dentures, an effort was made to simplify the instruments, and a non-archon instruments were designed. But lately, this archon principle has been incorporated again more universally in the later instruments since, let's say, since about 1960. We now have a number of instruments of similar design of the archon principle. Now we can go a bit farther in terms of jaw relation records and make a pantographic tracing. This is going a little bit far for complete dentures because the instability of bases, the soft tissue displacements. Actually, a pantograph is much more applicable with the natural dentition when we restore the natural teeth, fixed partial dentures, for example, and so forth. However, if the bases can be secured well in the mouth, that they're firm, a patient with good ridges, for example, and the central bearing point can be placed accurately enough so not too much tilting of the bases occurs on the soft tissue in the mouth, one could make a pantograph tracing as shown here. Now we get 6 tracings. We get 2 on each side of the posterior elements and of course 2 anteriorly. This gives us much more information which we can put into the instrument now. The patient has given us more of a lateral movements, and we attempt to trace out these movements by adjusting the various guides of the instruments. For information, this can be put into the instrument. Then you go back and get a good centric relation record to mount the lower to this programmed instrument, which is a result of all these tracings made about the patient. Another instrument, or another record really that can be made, is an engraving method or a stereographic method. An engraving method implies that we trace out in the patient, either on compound with some studs mounted in the upper, or as shown here in plastic, the various movements of the mandible. In other words, 4 studs, contact below, the patient moves the lower jaw around in definite excursions, protrusively and laterally, and we come up with then the tracing, and the instruments can be adjusted, or the instrument guides can be adjusted now to the tracings made in the mouth. This is an extension of the graving method called a stereographic procedure, where after the case is mounted, now in a centric relation record, and the tracings have been made, we can actually trace out the fossa inclinations. At the time after mounting, again, plastic is placed in these elements on each side, and the opposing members in the instrument are moved about, and you trace out the actual paths made. Now this simulates then the paths created in the mandibular fossa. It's a rather ingenious instrument. However, again, it is somewhat time-consuming to use in terms of tracing out these particular elements, but it's certainly a closer reproduction of the posterior controls. We can now move and hope to simulate the patient's movements even more closely than with positional records that we made earlier. Perhaps not better than with a pantograph record. The two are quite correlate to each other. But because actual guiding factors are reproduced in these elements on each side, this is called a stereographic proceeding, stereographic recording. The instrument is a TMJ instrument, which is a logical name really for the instrument because you're simulating the TMJ fossa in these elements on each side of the instrument. Now lastly, we also have a generated path procedure. This is applicable to removable partial dentures. It's also applicable to complete dentures. However, one denture must be made first, must be completed first when you make an upper and a lower denture. One denture must be completed first to a curvature. There's a step-by-step procedure through which this can be done. And then the occlusal paths are traced out on wax, and a template made, as shown here for the removable partial, and the teeth are set to the template, as we have done on the opposite side already. Now, for this procedure, we need only a simple holding instrument again. We can use this type use it as a simple holding instrument, or we could have used one of these that we showed earlier, because all you need is really a hinge instrument. Now this is all, though, if you do not change the occlusal vertical dimension. Again, whenever we anticipate a change in occlusal vertical dimension at any time in subsequent records, we should have a faceboat transfer. For this particular instrument, we don't have the equipment here, but there is an additional feature that can be added to this instrument, and one can make a faceboat transfer on this instrument too. But we did want to bring up the generated path procedure because it is a fine procedure for tracing out in the mouth actually the paths of one arch of the teeth into the occlusal wax, which can be used in the opposing arch. We mentioned earlier that we wanted to illustrate only instruments which are in current use. All of those that we have shown are in use at this time. However, it depends again on the number of records that a dentist would like to make on a patient, how far he would like to go to get information from the patient to make the dentures. But we should review once more the articulator classification so that we have these in mind. Now we do have the simple holding instrument. It might move vertically or it might move on a hinge, but that's all the movements that can be made. We have the average value instrument, which we recall is the one that has condylar elements set at predetermined values such as 30 degrees in relationship to the horizontal on the instrument. We have the tripod instrument, which now the average value will accept only eccentric relation record 2 as a simple holding instrument. We have a tripod instrument which will now accept lateral positional records also, but not necessarily require a facebow transfer. And we have the adjustable axes instruments, which may be semi-adjustable, those instruments which only accept a protrusive record, or the more adjustable instruments which will accept also lateral positional records, also pantographic recordings, or the stereographic type where we actually form the condylar elements on the instrument. And lastly, of course, a simple holding instrument can also be used, as we showed, with the occlusal path technique or the generated path procedure.